Good morning. Good morning. I'd like to go ahead and welcome everyone to Grand Rounds. We're delighted to have a very special guest, Dr. Dan Burkhoff, who joins us from New York, where he was born and raised, and completed his Bachelor of Science in the late 70s in Applied and Engineering Physics at Cornell University. Then spent 13 years at Johns Hopkins. He obtained a Doctorate of Philosophy and a Doctorate of Medicine. He completed his internal medicine and residency in cardiology fellowship at Hopkins, and was on faculty for roughly around 10, 11 years at Columbia, rose to associate professorship, and really has been a lead figure in the world of hemodynamics and its application. And many of you are familiar with Harvey applications, which is he's been really the developer, and in terms of dissemination, really seen as the expert in hemodynamic and education and teaching, and providing us better understanding of shock and devices. Between 2008 and 2014, he was the chief medical director of Circulite, which is a miniaturized novel partial assist pump, and for the last few years, VP of medical science at HeartWare, which we all know is a company that's put forth a long-term durable pump in terms of bridge to transplant. So really, on the basis of his international expertise, extraordinarily well published in the field, one of the gurus in hemodynamics. It's a real privilege for us to hear about innovative strategies for what's real for us in terms of heart failure with preserved EF. Dr. Burkhoff, appreciate you being here.
Thanks. Thanks very much, and it's really great to be here. And I'm going to talk to you this morning about certain aspects of HFpEF. Now, the field of HFpEF, I think, is filled with a lot of controversy still about, what is HFpEF. And I'm going to try to avoid all that controversy, because I think some of you have read some of my early papers from the early 2000s. It's really, we're kind of on one of the extremes on, the role of diastolic dysfunction and how diastolic dysfunction plays into the whole HFpEF thing in the broad sense. So I'm going to avoid some of that and really focus on some of the potential strategies that we have for this. And most of these things I'm going to talk about, none of these things yet are in clinical practice. So I'm going to talk a lot about some theory and some early clinical experience and preclinical experiences. So what is HFpEF? It's obviously a syndrome of clinical heart failure where the left ventricular ejection fraction is preserved. There are many different underlying conditions that really make up this broad disease. And I think that one of the things that is important to, I think from my perspective, has been important to recognize is that these different diseases that contribute result in different kind of hemodynamic phenotypes. So we have patients with hypertrophic cardiomyopathy. We have patients with restrictive and infiltrative disease like amyloid, which is becoming very much more now appreciated that amyloid contributes a huge amount in the general population to HFpEF. We have then what we refer to as kind of the garden variety of HFpEF, which are these patients who have multiple comorbidities, most notably hypertension, but then also mixes of coronary disease, prior MI, diabetes, chronic renal failure, obesity. And in this condition, the LV is not necessarily small or overtly small like it is with the other conditions, and cardiac output is not necessarily decreased in this group. And then there are other different conditions that will lead to HFpEF. Now, despite all the differences, there are many common features independent of which kind of category a patient will fit into. So first of all, I think you all know that an enlarged left atrium is really a common feature in this group. They all have elevated BNPs that go along with that. That's a reflection of the high filling pressures that they have. They do have in many of these subgroups, they have very small ventricles, and at the worst, they're minimally dilated. They don't have, obviously, very large ventricles like we have in heart failure reduced ejection fraction patients. And in addition, they also have significant exercise intolerance. And this has really been a topic of a lot of research. Why do these patients have exercise intolerance? And the factors that have been looked at include, but not limited to, chronotropic incompetence, reduced oxygen extraction from the periphery like we have in other forms of heart failure, and elevated pulmonary venous pressures. So these, again, independent of which of these subgroups you are in, these are some kind of the common things that we could look at and are all potential targets for treatment. So this is a classic study from Barry Borlaug, who's really was one of the original people when he started at Hopkins and now is at Mayo Clinic, and he has really been picking up on characterizing the exercise physiology in HFpEF population. And these are mainly the garden variety HFpEF patients, those, the hypertensive patients, and like usually, 60%, 70% of these are female. And these are the results of exercise testing. This is the wedge pressure, and the black shows age-matched controls, and the red are the subjects. And this is it goes from baseline to this is now with supine exercise patients on a cath lab table, and then a bicycle on the cath lab table. The first thing that they do is just raise the legs, and raising the legs into the pedals of the bike is kind of like giving a bolus of 250 to 500 cc from the legs. It comes to the central location. And what you could see is even if these patients start with a normal wedge, and here you see it's around 10 millimeters of mercury, just raising the legs into the pedals increases the wedge pressure by about 8 to 10 millimeters of mercury. Pretty astounding compared to the controls. And then the patients start exercising, and within 1 minute, going into exercise at very low level, 20 watts is usually the starting level, you could see here that the wedge can shoot up to about 30 millimeters of mercury, and then these patients can exercise relatively minimally. 40 or 60 watts is kind of a typical range that these patients can reach. They reach, on average, the group on average would reach around 35 millimeters of mercury, but we could see sometimes patients reaching wedge pressures of 50 millimeters of mercury. And then this, of course, once they stop exercising, this goes down rapidly. And this is a very profound, obviously, difference between the controls. So this has been, these kind of data are reproducible now in many labs, in many hospitals that have HFpEF clinics, or where they have clinics where patients have shortness of breath with undefined etiology. Exercise testing, invasive exercise testing, has become part of the standard workup, and you can see this, and this really can help differentiate patients with HFpEF and those without HFpEF. Now, I mentioned that there are these different types of underlying conditions that will result in HFpEF, and these are echoes from 4 of these different classifications, and I'll come back to this 4 subclassifications multiple times during the talk. So you'll all be very familiar. I won't go through the details, but we see that this is like one clear diagnosis that you can make: hypertrophic cardiomyopathy. Another diagnosis that you can make relatively easily is amyloidosis, and this, again, now it's turning up that in the general population of HFpEF, as many as 30% of patients have some type of amyloid. This is on the bottom right is the group with the hypertension and other cardiovascular comorbidities. And then working, and I'll show more detailed data on this, but working with some, in our experience, some 2 different populations that we had, one in New York and one in China, from one of my fellows that went back to China, and also now reconfirmed with Sanjeev Shah with his database in Chicago. We've identified a small group of patients that have non-hypertrophic cardiomyopathy. These are patients who have LVEF greater than 50%. They have the clinical syndrome of HFpEF, but they don't have hypertrophy on their echocardiogram. The ventricular wall is less than 1.2 centimeters. So we called this non-HCM HFpEF. So these are the 4 what we've seen as the 4 main subgroups of HFpEF. And some authors have tried to subdivide HFpEF into at least 7 different subcategories. But in our our work, we've been focusing on these four different subgroups. And so what we did was we went back to the literature and also to clinical databases that we have, and we looked at the hemodynamic characterization of these 4 different subtypes to see whether or not there's any phenotypic difference between these patients. So here we've got these 4 types, type 1, 2, 3, 4. And the things to note are that are shown by the red arrows. First of all, the septal dimension is large except in this non-hypertrophic group, and that's by definition. And the same is true for the posterior wall. Ejection fractions, of course, are preserved. These patients all have some degree of pulmonary hypertension, and a lot of that is due to the fact that they also have elevation of the wedge pressure. So the pulmonary hypertension a lot of times is just secondary to the increased afterload provided by the elevated pulmonary capillary wedge pressure. And what you can see here, at least from these sources, and the references are provided in the paper, but you can see that actually these patients with hypertension, the hypertensive subgroup of HFpEF, had the highest wedge pressures of all these subgroups. Pressures are different because in the real patients who have let's say the hypertrophic and the infiltrative and this non-LVH, these patients have low blood pressure. But by definition, the hypertensive patients have a high blood pressure, and that makes a big difference in the physiology and pointing towards, hinting towards the difference in the mechanism of the underlying disease. So the hypertensive patients really stick out in terms of blood pressure. These other groups, again, have real, like what I refer to as real bona fide diastolic heart failure. And as a result, they have low blood pressure, just like you have in systolic heart failure. The other thing that sticks out is the cardiac output. And the patients with the true diastolic heart failure, the HCMs, the infiltrative, and the non-LVH patients have low cardiac outputs, but the hypertensive patients, at least at rest, have normal cardiac output. The PVRs and the SVRs are also kind of distributed and clearly not normal compared to normal groups, but they are relatively similar between the groups. So these are the hemodynamic characterizations of these four subgroups that we've kind of been looking at. Now, in terms of treatments, I'm sure that you're all aware of the ongoing situation where one study after the next is negative with regard to medical pharmacologic therapy. And these are just four of the studies that have been completed or are ongoing. And I won't go through the details, but LCZ, soluble guanylate cyclase inhibitors, isosorbide mononitrate, and spironolactone, these studies have all been negative so far. And when like in systolic heart failure, as medical therapy kind of started reaching a wall and started becoming piling one drug on top of the other incremental, we started then turning to devices. And so the question that we were faced with, and we've started to be involved with several projects, is how can you design devices that might help for patients with heart failure? And that's really going to be the focus of the rest of my talk. So there are three approaches that have been proposed now, device-based therapies. The first one really that came out was this intraventricular spring. And the idea here was that literally you would put a spring inside of the left ventricular chamber with the idea that the heart of these patients can't dilate enough to have enough preload, and therefore if you can put a spring in that would increase its dimension, it would fill better, and therefore there would be better emptying, and you'd cure this. You'd be able to treat this disease. So the idea was really to transfer energy from systole and to use that to improve diastolic dysfunction. The next idea that has come up is this interatrial shunt idea, and there are two efforts now that are in clinical trials, and I'll talk about these. The idea here is, as we talked about, the left atrial pressure in the left atrium is large, and the left atrial pressure, the wedge pressure, is high, especially during exercise. So the idea here is to provide basically a pop-off valve when the pressure gets high, that you'll just allow shunting, left to right shunting, so that the pressure won't increase in the left atrium, and that should then improve exercise tolerance. And then finally, we've recently proposed the use of mechanical circulatory support. And there is a history of the use of mechanical circulatory support that I'll review and talk about where the field has been and where we've proposed it can go with using new devices that are not yet in the clinic but are in design. So what's the status of these three projects? Well, this intraventricular spring idea had some initial data. There was some very interesting work done by Bill Little, actually, in animals. And there was some work done in outside of the U.S. in patients with aortic stenosis who had severe hypertrophy. But I think that in the end, I think investigators realized that this was probably not going to be a winner. And as far as I know, this is not being pursued anymore. And to be honest, this really did not make a lot of sense to me, because whenever you're taking energy from one place to use for another place, in the end, you don't, it's a balance, you don't really gain anything. This is a situation in cardiovascular system. You have to put energy into the system to make an effective change. So I think that that this is now not being used, not being pursued anymore. And I include it just from a historical perspective, just to let you know that there's been a lot of different approaches that have come and gone now, even in the field of HFpEF. Now, with regard to the intraatrial shunt, there are two different devices that are in trial. Both of them have completed pilot studies and feasibility studies, and now one of these devices has completed a CE mark study, meaning they've completed about a 60-patient study in Europe and have applied for regulatory approvals in Europe and is now entering clinical trials here. And in fact, the first patient randomized into the U.S. was this past week. The difference between these devices is that one just creates it's a nitinol cage that just opens a communication between left and right atria, and this nitinol cage is really intended to allow the healing and to maintain the integrity of that septal defect. The other one is a similar cage, but it has, you see here, it has all these coverings, and also the main thing is that it has a valve. And the idea of the valve is to prevent right to left shunting. So if you just have an ASD, obviously, if you have a situation where the pressure is higher in the left atrium, no problem, you'll have left to right shunting. But if on occasion, with certain maneuvers, during coughing or during exercise, during Valsalva, you can increase your right atrial pressure greater than left atrium potentially, and that could cause right to left shunting, and that could potentially be a problem. So this approach actually has a valve, and the question is whether or not a valve of that small size can maintain patency in this position, which is in the end going to have very low flow. Now, with regard to mechanical circulatory support, there is clinical data with currently available devices, but mainly with the HeartMate 2 and the HVAD, and we were developing this pump called the Circulite pump for systolic heart failure. It's a minimally invasive, it's a smaller device. It has the potential for interventional implantation, and it also has a lower flow capacity. It goes down to like 1 liter a minute and up to about 4 liters a minute. And we thought that this could have potential applications for HFpEF, and I'll talk about that. So I'm going to talk now about these two approaches. So the intraatrial shunts, these are the two devices. Again, the idea is to allow flow from the left to the right atrium. Here you see, again, the main difference is that this device down here has a porcine pericardial valve that is intended to prevent right to left shunting. The idea is that during exercise especially, patients have elevated filling pressures. That leads to pulmonary venous congestion and pulmonary edema and dyspnea at rest and or during exercise. So the idea is very simple. Prevent this left atrial pressure buildup, especially during exercise. And therefore, the hypothesis is that you would be able to then exercise longer. So on this graph, the hypothesis is that you would, instead of having this very steep climb, you would be able to blunt that rise in pulmonary pressures, and then patients would, in principle, be able to exercise longer. This really rests on the assumption that exercise tolerance is limited by the rise in pulmonary capillary wedge pressure, and that is not necessarily a proven thing at this point. But it certainly is one viable target. There have been trials in the past that have tried to address the chronotropic incompetence, which really failed. So this is trying to address the rapid rise in pressure during exercise. So there were really no animal models for this. And so before going into clinical trial, we worked with the group And we did some computer simulations of what this potentially could do. So this is an electrical analog of the cardiovascular circuit. And this starts with the left ventricle. You have the peripheral circulation. You've got the right atrium, right ventricle, the pulmonary circulation, then coming back around to the left atrium. And by putting a resistor between the right atrium and left atrium, we can simulate what this device would do. And this, by the way, is kind of the... So this simulation, which is now represented in electronic corollaries of the hydraulic system, can be characterized by simultaneous differential equations that could be solved in real time and give you a real-time dynamic cardiovascular system, simulation of the dynamic cardiovascular system. And this is what really is driving the Harvey app that we've been developing for educational purposes. When you see the pressure volume loops on the screen of the Harvey app, this is really what the Harvey app is doing in real time, solving the differential equations here. So we simulated the typical patients with HFpEF, and we looked at shunt diameters of different sizes, and we predicted what will be the effect on the left and the right side of the ventricle. And this is basically showing in blue the pressure volume loops in the 4 different chambers. And the red shows, the blue shows the baseline, and the red shows what happens when you put the shunt in. So it's pretty simple. Obviously, when you put the shunt in, you're going to reduce the pressure in the left atrium, and you're going to increase the pressure a little bit in the right atrium. And that's going to have an effect of reducing the filling on the left ventricle and increasing a little bit the filling on the right ventricle. But because of this marked reduction in the left atrial pressure and therefore the pulmonary wedge pressure, you're not going to really have an increase in the pulmonary pressure. So that's another thing that we talked about before, is that the wedge pressure plays a big role as contributing to the afterload on the right ventricle. So here we have, although we're increasing, let's say, the volume load a little bit on the right ventricle, it's offset by the decrease in the afterload, so that you really don't have a significant change in the pulmonary pressures. So this is what we predicted. With regard to this is now showing the difference between, this is left atrial pressure in red and right atrial pressure in blue. And as you make this shunt diameter larger and larger, these pressures will come together. So you imagine if there's a really large shunt, obviously the pressures will be the same. And so the question was, one of the first questions we were posed with the simulation is, how big should we make this shunt? So this is our theoretical predictions, and the engineers then basically, partly on this, settled on 8 millimeters of mercury, so that we were able to, as being a size that would get most of the benefit and not be excessively large. So most of the benefit is really achieved by this 8 millimeters, it seems. So those were our predictions, and the clinical trials have, as I mentioned, with this particular device, have now enrolled about 60 patients. And this is what the device looks like during deployment. It takes about 10 minutes to deploy this thing once you've got your needle across the septum. And here it is in the fully deployed position. Now there's a TEE showing the shunt. This is the one that's non-valved, and you can see the flow across the shunt is basically throughout the cardiac cycle, indicating that there's really a persistent and pressure gradient from left to right. The left atrial pressure is always greater than the right atrial pressure throughout the cardiac cycle, so you have continuous shunting. These are some images from, I don't have the cines, but these are the images with the valved device, and you see a similar kind of a thing. But even with the non-valve device, because of this persistent pressure gradient, there's left to right shunting without any right to left shunting, at least under these resting conditions. So CE mark, the study was done in Europe, and there's been 63 patients that are enrolled and have now completed 6-month follow-up. The results of this trial have not been released yet, but just to show you the baseline data, these are older individuals. And in contrast to all the systolic heart failure, we have a reverse here that 65% of the patients enrolled are women, which is reflective of the population of HFpEF in general. EF is obviously preserved. These patients were predominantly New York Heart Class 3 at rest. There was, of course, a high degree of atrial arrhythmias at baseline. Most patients had hospitalizations. The rate of hospitalizations was 0.3 hospitalizations per year prior to. They have a poor quality of life as indexed by the Minnesota Living with Heart Failure score. And they have an elevated NT-proBNP, but not hugely elevated. And that's very typical for HFpEF. A lot of times these patients won't have very high NT-proBNPs, and I don't know if that's consistent with your experience. But that is also a reflection of the fact that these patients, when they're at rest, they may not have very high wedge pressures, but when they exercise, so they only have these periodic elevations in the left-sided pressures. And there's, of course, a lot of comorbidities, the predominant one being hypertension. So I think, in general, these were the garden variety HFpEF that we think about. These data have been presented by Sanjeev Shah. And there's preliminary 1-month data that's been presented just on the clinical side, showing some reductions in the New York Heart Classification, reductions in the rate of hospitalization comparing pre to post implant, improvements in the Minnesota Living with Heart Failure score, and a little bit of an increase in the 6-minute walk test. But now, so these are clinical data. This is an unblinded study, so I think you have to take these data with a grain of salt. But the real endpoints of this study are hemodynamic endpoints. So these patients all underwent catheterization, right heart cath with exercise at baseline and at 6 months. And as I mentioned, the study has just been completing. The CE mark has been submitted, and the publication was actually accepted just this week to Lancet. So I can't reveal the results of this, but they will be very forthcoming. And also for us, looking at these results, it's also another opportunity for us to test the validity of the cardiovascular simulations that we've been developing and using to try to predict results of clinical trials and to help with device design. So there is, as I mentioned, a randomized single-blind study that's just been initiated, first patient randomized this week. All patients will undergo non-invasive testing followed by invasive hemodynamic stress test. And if they meet the inclusion criteria, they will be randomized on the table to either get or not get this device. The patients, like with some of the other interventional trials that attempt to blind the patients and the investigators, the patients will be sedated and have music playing with earphones so that they're not really aware of what's going on. And so the idea is to maintain the blind for the patient. It will be probably difficult to maintain the blind throughout the rest of the, for the physicians, because you can see these things on X-ray, on echo, et cetera. But at least the patients will be blinded, and then this will be a 12-month follow-up. So I think this is really, like with reduced EF heart failure, we need to have randomized, blinded studies to really sort out the true benefits of these. And so this study is now initiated. So with regard to the interatrial shunt story, there are these 2 devices in trial. Pilot and the non-randomized studies are completed. New data accepted for publication should be out very soon, and randomized study is initiated. So that's the interatrial shunt idea. Now, what about mechanical circulatory support for HFpEF? So this is a very interesting story, and there's been some very limited experience in patients with various types of HFpEF, and in particular restrictive and hypertrophic cardiomyopathies. The largest series that I think has been done and that has been published is these 28 patients from the Mayo Clinic. And this paper just came out late last year. And some of the issues, so these are patients who got these are mainly HCM and restrictive cardiomyopathy patients. And they got either HeartMate 2s or HVADs. And in the abstract, the results are very clear. There were a lot of complications in these patients. The first was postoperative right heart failure requiring short-term medical support, and in some cases, RVADs was higher than in the general population of reduced EF. The short-term in-hospital mortality was 14%, which is now, that's almost the one-year mortality. It's actually greater than the one-year mortality for patients with HFrEF. And one-year survival for patients with LVADs without transplant was 64%. So very poor outcome with these, even with LVAD. And in their analysis, left ventricular end diastolic diameter less than 46 was associated with increased mortality. So the smaller the ventricle, the worse the outcome. And this is really the bottom line. So it suggests that using mechanical support and pumping from the left ventricle is really not going to be a viable option for these patients. So on the other hand, as we discussed already, the left atrium in all these patients is large. So the hypothesis that we generated was that left atrial decompression with a pump, instead of putting the inflow cannula into the left ventricle, put it into the left atrium, and maybe this would be a way to treat this population. So this is where the Circulite partial support device came in. So we were investigating the use of this device in heart failure reduced EF basically for Intermax 4 patients. As you know, most devices are put in for Intermax 3 and 2 now. And the Intermax 4 group, there's less strong data for that. And our hypothesis with this device was that if you could make a less invasive device that would be associated with less adverse events, that you could then, and you could provide a clinical benefit, you would then be able to rationalize, justify using MCS in the less sick, quote unquote, less sick patients. Our initial device, so that the pump is very small, it was the size of a AA battery, and it connected to the heart via an inflow cannula that was put into the left atrium. So this is the surgical approach here, and the outflow was to the right subclavian artery. And the goal of this project always was to make this as an interventional device. So again, you would put the pump basically in a pacemaker pocket and have a surgical anastomosis to the right subclavian artery, but the inflow cannula in this case would be introduced via the subclavian vein down the superior vena cava and via transeptal reach the left atrium. So the blood flow pattern would be from left atrium to the pump back to the subclavian artery. So this would be an interventional-based device, and in our minds, do what TAVR has done to aortic valve replacement for mechanical circulatory support. So imagine, if you have your relatively sick patients now, you can get them a VAD not by going to the OR, but by going to the cath lab and doing this under conscious sedation. So this is our goal. This was our goal. We achieved some success. We treated about 90 reduced EF patients in Europe, and we had a lot of physiological success, but the device had an excessive amount of thrombosis, so we had to stop the trial, and this is when HeartWare took over the project and is now in the process of redesigning this pump to be more robust and thrombus-free. The components are just shown here. This is the pump. This is the inflow cannula for the surgical device, and I'll show the interventional one a little bit later. It's really a little bit larger than a AA battery. This is the redesigned pump from the HeartWare. And with regard to heart failure reduced EF, we enrolled, as I mentioned, in the clinical trial. This is results from 27 patients with heart failure reduced EF, showing the clinical benefits of this pump, which is now on average pumping around 2.5 to 3 liters. So we're not pumping. You're not pumping 5, 6, 7 liters. We're pumping really a little bit. And again, these are Intermax 4 patients, so they are not patients in cardiogenic shock or fully inotrope dependent. We are able to show that these patients, we were able to increase their net cardiac output back up to normal, to around 5. But really, the main thing that we were able to do very quickly and sustained was to reduce the pulmonary wedge pressure, reduce the left atrial pressure, because we were sucking right from the left atrium. We had this really dramatic and abrupt and immediate reduction in left atrial pressure. So that's really what got us thinking about, well, maybe this would also be an appropriate approach to use in patients with HFpEF, where one of the main problems is this marked increase in wedge pressure, but also, especially in the hypertrophic and the restrictives, we have this limitation of cardiac output as well. So again, Our approach was to go to computer simulation since we don't have an animal model. This shows the circuit that I showed you before, but now instead we can put in a left ventricular assist device, and we can take blood either from the left atrium or from the left ventricle, and we can predict what is going to be the physiologic effect of these different approaches. So this is what happens when you pump from the left ventricle, the traditional way. And we've simulated here a typical restrictive cardiomyopathic patient, has a small left ventricle, 75 mLs end diastolic dimension, end diastolic volume. And here's the left atrium with a very high left atrial pressure. And then what we did was just turn this pump on and increase the RPMs. And what you could see is what you would expect is as you increase the rate of flow through the device, you increasingly unload the left ventricle, which is what we want to do, and you reduce the left atrial pressure, which is all great. However, what you see is also as you increase that flow, your end systolic volume in the ventricle is getting smaller and smaller. And now you start out with a small end diastolic dimension. Your end systolic dimensions are less than 25 cc's. And this is a situation where you're sure to get suction and have all sorts of problems that were noted in the clinical trials. So this really is just highlighting on the just graphically what's happening when you use MCS in a small ventricle. And you can imagine that this would lead to all sorts of problems with inflow. On the other hand, if you take the blood from the left atrium, you have a different situation. And this is very much like the tandem heart approach, where blood is taken from the left atrium and put back into the arterial system. So there is experience with this approach in the acute setting. So when you pump from the left atrium, again, you have this rate-dependent, flow-dependent reduction in the end diastolic dimension. So you unload the ventricle. And that, of course, you're sucking right from the left atrium. So you have that same unloading of the left ventricle, of the left atrium, and the reduction in pulmonary wedge pressure. However, the end systolic volume reacts in a different way. It doesn't decrease because now you're increasing the afterload on the ventricle due to the increase in the flow that you're providing. And as a result of that increase in afterload, the end systolic volume will increase or for sure not decrease. And that is really a good thing in this HFpEF population. So now we have preservation of pumping of the left ventricle, whatever it can do, but we have this unloading and marked with only about 2 liters of flow, you can really decompress the ventricle from, let's say, the atrium from a mean pressure of 20 millimeters of mercury down to about 5 millimeters of mercury. So this is all theory, and these are again, this is theory of what if we do this in these different forms of HFpEF. So we've got, again, these 4 forms, and the black shows the baseline wedge pressure, and the blue shows what happens if we pump from the LV, and the red is what happens if we pump from the LA. Well, we basically, in all these forms of HFpEF, we get the same reduction in the wedge pressure, so that's good, no problems there. And this just shows also the impact on total cardiac output at rest. And we basically have the same increase in cardiac output independent of whether we pump from the LV or from the left atrium. So this seems to be, at least on the theoretical side, a viable approach for treating HFpEF. So the question then arises, what are the clinical considerations that would cause you to use or to consider mechanical circulatory support in HFpEF? And this becomes a little bit more of a complicated situation because a lot of these patients with HFpEF are not, some of them at least, are not in dire straits. They're not in INTERMAX 3, INTERMAX 2. They're not suffering at rest. They would be considered more like the INTERMAX 4 patients. And you're taking those patients and exposing them to a lot of the risks of MCS and also the risks of chronic anticoagulation. So when would a clinical situation justify the use of HFpEF in mechanical circulatory, the use of mechanical circulatory support in HFpEF? Well, the INTERMAX definitions are not applicable because we don't have the same kind of treatments for HFpEF as we have for the HFrEF. Again, we have to consider the adverse events and the impact of long-term anticoagulation. So there were 2 things that we considered and we wrote about this in our paper, was that the use of potentially the use of the Kansas City Cardiomyopathy Questionnaire might be able to differentiate or to stratify patients at the highest of risk. And this is a paper from St. Louis, Susie Joseph and Doug Mann, where they looked at the Kaplan-Meier curves for death or rehospitalizations in HFrEF and HFpEF using the KCCQ. And this is HFpEF and HFrEF patients combined, but over here is just the HFpEF patients isolated. So you could see here that if your Kansas City questionnaire is between 0 and 25, you've got an extremely poor prognosis. This is true for both hospitalizations and mortality and just mortality alone. So this is one potential way to go for identifying those patients who are in the worst shape and maybe where you could justify use of MCS. The other thing that we did was we took the Intermax gradings and I'm not going to go through this, but we started looking at, well, what would Intermax scores look like for HFpEF? Because the Intermax classifications have been so helpful in reduced EF, in selecting patients for mechanical circulatory support in the HFrEF group, that we thought maybe there would be a way to modify those definitions that would be applicable to the HFpEF. So I'm not going to go through this again, but other than to say that this would be like a starting point, I think, as these devices perhaps become available and we start thinking about how to approach this population. This might be a starting point for discussion among the community. The other important consideration, as you know, especially for the garden variety of HFpEF, many patients die from non-cardiovascular diseases. So this just shows in black the cardiovascular death, and the white is non-cardiovascular death. And depending on which series you look at, between 30 and 60% of patients with HFpEF die not from cardiovascular disease. They die from other diseases. So that's unlike obviously that's unlike the HFrEF, where 90% of patients with heart failure or reduced EF die from a complication from their disease directly. So this is another important factor that we have in mind, as we think about approaching this population. And so we published this paper, and then this letter to the editor came out from here. And initially we were very nervous, because you're always nervous when you get a letter to the editor. It's like, you stupid people, why'd you bother publishing? Why'd you bother proposing this? But I just put the first sentence because in the end I thought I really felt that the letter was basically endorsing the concept, at least on the exploratory level. So thank you very much for that. That was really, really. We were sweating a little bit before I got the. So the end game for the Circulite is really the percutaneous device, and this dream lives on. It's delayed, but continues to advance. The idea I mentioned already was that this mechanical circulatory device, the pump itself would be put in a pacemaker-like pocket with an anastomosis to the subclavian artery via a surgical anastomosis. But the inflow cannula would really come from an interventional deployment of the cannula through the subclavian vein. The tools for this have been all developed, and we were very close to doing a patient when we just said, okay, the pump is just not robust. We actually had a patient ready to go, and we said, we just can't, the pump is just not up to it. But this, the business end of the pump this is what gets left behind in the left atrium is just this little tip, and you see these Dacron-covered nitinol fingers kind of grab the septum and keep the device in place. And in animal studies, you can see that these Dacron-covered nitinol fingers really get fused into. They heal very well into the atrial septum, and it's a very nice. It's really a nice thing. This is just a quick animation of the idea that you put a wire across the septum, and then everything is done over the wire, just like interventionalists like to do, through a guiding catheter. That's the guide wire. Then here comes the front end, gets deployed, and you pull back. You can see the tenting on fluoro or on ice, and then you deploy the back end. And that's as simple as it is. Once we have the wire across, again, with it's like a 10 or 15-minute procedure. If you get in the right spot, the non-muscular part of the interatrial septum, and then you see here the blood flow again is from the left atrium through the pump and into the subclavian artery. So we already have the surgical validation that using this can provide clinical benefits, and it's really now waiting for the pump to be improved. So in summary, HFpEF is a syndrome that can result from different underlying diseases and pathophysiologies. Diastolic dysfunction, in my mind, is the main pathophysiologic mechanisms in patients who have hypertrophic cardiomyopathies, restrictive cardiomyopathies like amyloid, and this non-hypertrophic cardiomyopathy that we've identified. I think like the more garden variety of HFpEF, I think, is less about diastolic dysfunction and more about volume overload states and rapid redistributions due to autonomic dysfunction. I think there's a lot now, as people have focused on HFpEF over the last 15 years. I think there's more acceptance of the fact that things other than diastolic dysfunction contribute to the pathophysiology and the clinical phenotype in those patients. Drug trials have failed to identify effective therapies. Device therapies have been proposed and are in their infancy. But I think, again, focusing on the common features for all these patients, which really is a large left atrium and high left atrial pressures at rest, and particularly during exercise, is a logical target. And whether or not that this confers clinical benefit remains to be seen. But the only thing that I've learned is HFpEF is complex disease, and I think there's still a lot of room for a lot of physiology to be done in this field to move it forward. Thank you.
Dr. Burkhoff, thank you for that fantastic review, and I think we're entering the era of device therapy for heart failure reduced EF. We're well into it, obviously, but now with preserved EF, I think intriguing, and the concept you put forth, just wonderful to hear. Let's jump into questions.
So my question is, I appreciate that you separated out all the different HFpEF patients, because I think it's quite clear that those with restrictive cardiomyopathies are the ones that really have excessive morbidity, and it's not the other groups, because we have pretty effective therapies for the other groups. They kind of just revert into this chronic outpatient heart failure state, and they really don't go in and out of the hospital. Right. It's the restrictive cardiomyopathies that really need some sort of device therapy to keep them out of the hospital and keep them from progressing. With respect to those other populations, because it looks like with respect to these device therapies that it wasn't just focused on the restrictive population. So this is my question. If you put in these devices in the left atrium, because both of them are involving the left atrium or left atrium, right atrium, what is the incidence of atrial fibrillation? Because in this chronic heart failure HFpEF population, which is predominantly hypertensive, they don't get into trouble and they don't go into the hospital until they develop atrial fibrillation. Mm-hmm. And we know from closure studies with PFOs that there is an increased incidence of atrial fibrillation when you put those devices in the left atrium. Yeah. So that would be my question, because potentially you could be worsening a whole bunch of stable chronic HFpEF patients.
Yeah. So part of the background for the interatrial shunt research was to actually look and see what happens with closure. When you have naturally occurring PFOs, what happens when you close? And as you know, there's an incidence of patients going into heart failure when you close an ASD. A small incidence, but you can, if you have an adult and you abruptly close something, you can actually induce heart failure. So I think that the reason for the atrial fibrillation is I don't think it's the presence of the device itself, it's the high pressures and the stretch. So the idea here is that you decompress, and we should have a reduction in atrial fibrillation. And in fact, as you saw with the atrial shunt study, I think there was incidence of 30 to 40% at baseline of these patients had atrial fibrillation. And I think that the follow-up, again, this will be in the paper, is that there was certainly no increase in atrial fibrillation, and it was a small number, but there was a decrease in the amount of atrial fibrillation. So not all those patients were permanent AFib. There was a lot of persistent AFib. So we did see a slight reduction in the amount of atrial fibrillation with those. So I think it's not due to the presence of the devices, it's due to the pressure itself. So we would expect that we should reduce the amount of atrial fibrillation. Now, with regard to your other comments, I totally agree that the largest potential population for the pump for the mechanical support is the restrictive cardiomyopathies, the amyloids and other restricted. If you think to your patients that you see in clinic, as you mentioned, and like you're looking at them, you say, would I put a pump in this patient, right? So these, older women, you're not going to have a high likelihood of putting pumps in, I don't think, in those kinds of patients in large numbers. There are other things I didn't talk about which I think are negatives for that population for mechanical circulatory support, which include the fact that they're hypertensive already. You're going to increase their cardiac output. You're going to potentially increase their blood pressure further, and you're going to put them on anticoagulation. These are all the things that are risk factors in the HFrEF population for thrombosis and stroke. So for me, the real population, and we talk about that further in the paper, but for me, the real population is this restrictive cardiomyopathy, because you see those patients and you could say, wow, you see these patients just die without, if you don't do a total artificial heart or get them a transplant, they really have no option. So that really is, I would say, our largest target, and I think the HCM patients are equally, they may not be as many, but there are some I think that could potentially benefit as well from that approach. So I think that's what I think the RCMs will be more for the MCS and the garden variety. If this interatrial shunt works, I don't know if it's in the end going to work. We're still in the early theoretical phase, but I would see that more for the garden variety hypertensive patients.
Hey, Daniel, it's good to see that both you and I are still here.
Hi. Hi.
It's also good to see that you're still thinking outside the box.
Thank you.
This is really a very innovative concept, and I'm still trying to put my head over it. But one point I wanted to bring to you is a lot of large series now have shown that somewhere between 10 to 12% of patients with HFpEF and also with HFpEF, actually on both groups, have severe pulmonary hypertension with pulmonary vascular reactivity. Well established, the syndrome exists, very well known, we still don't know what the hell to do with it.
Yep.
Now, the question here is, when we suck from the left atrium, we return to the RA, we're keeping cardiac output unchanged or maybe even a little better. Could be, it's not going to go down because these people already have a reasonable cardiac output.
Yeah.
You're going to suck it from the LA, you're going to bring it back to the RA, so you're going to be maintaining more or less the cardiac output. You're going to lower the LA, you're going to pray that will bring the PA diastolic and PA systolic down, but if it doesn't, you have converted the patient to a traditional pulmonary hypertension patient. And I'm sure you've thought about this. The question is, how are we going to tackle that? Because that could be the elephant in the room when we actually manage this, because it turns out that these restrictive hearts are also the ones more prone to have the pulmonary vascular reactivity and the severe PhD.
Yeah.
And we have Dr. Park here, which I know have been thinking about this for many years. I could see this becoming a problem.
Yeah. So I think I'll divide the answer again between the MCS and the shunt. So with the MCS, I think it's pretty clear because, as you know, with HFrEF, you have this component of pulmonary hypertension. When you put MCS in, within a month, I think a majority of these patients, the pulmonary resistance drops and they become more reactive. So we're expecting that with the MCS, for example, in the restrictives, that we will see a similar drop in pulmonary resistance. I think that just seems to be the natural reaction of the bed to the reduction in the wedge pressure. In that case, we're not really going to increase the total cardiac output that much. So I think we're going to markedly reduce the afterload on the RV, and reduce those pressures will result in a reduction in PVR, just like in the HFrEF. Now, with the shunt, you don't think so? Yeah, hope. We hope. Now, if we're dealing with amyloid, if there's an implication of the underlying disease, in terms of interfering with the pulmonary, pulmonary reaction to reduction, I don't know. That I don't know. I don't know if anyone knows that. With regard to the shunt, I think this is more of an issue because we now have an increase, as you correctly said, because of the shunt. And by the way, the shunt fraction we predicted is 1.2 to 1.3, about 1.25, which is pretty low. And actually that turned out to be confirmed in the clinical trials. So we know we have a good handle on what that shunt fraction is. But now we have an increase in right-sided cardiac output. So now the question is the balance. We reduce the afterlobe by the reduction in wedge, but we now increase the pressure because of the increase in flow. So that is the balance. I know, again, without violating the Lancet embargo stuff, there's no increase in pulmonary pressures at this point that we've noticed in the 65 patients or so that we have the data from so far. So this was definitely a big consideration. We wrote about this in the paper. What's going to happen with the pulmonary bed, and I agree that we're going to need really good long-term studies because this is not something. I think this is really a long-term thing. We need to study these patients for years. As part of that consideration, we have a lower age limit, so we're not enrolling young patients. I think patients have to be, I forgot the age cutoff, but it's over 60 or 65. So, you don't want to have a person at age 30 or 40 have a shunt to live with for 40 years. That is one of the considerations. So until we have more safety data, we're trying to take a cautious approach to this and obviously looking very carefully at it.
Yeah, good. So related to the previous question so you decrease the pulsatile loading by decreasing the wedge, and maybe you unmask the resistive loading to the RB. From the practical standpoint, in your trial, there were any particular cutoff regarding PVR, pulmonary pressures, or how?
Yeah, the cutoff for PVR was 4 Wood units, arbitrary. But that was, we didn't want to take patients with super high PVRs. Let's see, we had age cutoff, and also we had a CVP cutoff of 14. So again, these are kind of arbitrary, but we didn't want patients who had overt right heart failure.
Is this being promoted as a relief of symptoms or progression, increase in life expectancy?
Excellent point. I think that the best that we can hope for now is a relief of symptoms. Second best would be reduction in hospitalizations. I think that we can, out of the box, improve mortality, especially when you see the data, which is part where I showed that slide that shows that on average 50% of these patients die from other things. I don't think that we're not really addressing any underlying disease here. So it's a symptom treatment, the treatment for symptoms.
So, comment and question. I think Dr. Torres.
Does the Monterey, do they have the ability to voice in? Or So comment in Roadmap, you're probably familiar with looking at the efficacy of permanent devices in heart failure reduced EF in patients that were ambulatory advanced heart failure, no survival advantage, some quality of life improvement. You want to carefully weigh the benefits and risks. And so when thinking about mechanical circulatory support for heart failure with preserved EF, in terms of trial design, consideration for FDA considerations, is quality of life going to be enough, or do you think you need an endpoint like hospitalization?
Yeah. So I think that a Roadmap had every study has some limitations, but I just think with Roadmap that the HeartMate 2 is not the right device to study. I really think that, and we also with Circulite we had an IDE approved to start a clinical trial in the U.S., but kind of the wheels fell off the bus all at once when the device thrombosis just popped up and we just had to stop everything. But I think that we need less invasive devices to treat less sick patients. I think that's the bottom line. The trade-off, obviously, with MCS is the adverse events. And We need devices that, if they, every device is going to have a certain amount of failure, but you need to be able to have a fail soft, meaning that it's not catastrophic for the patient, and you need to have a way to change the device quickly and safely and easily. So with a device that's a pacemaker, if it fails, you could change it like changing a pacemaker without even putting the patient under anesthesia. So I think that I don't think that we were ready for a roadmap with HeartMate 2 or with the HVAD. I think it's really, the HVAD was originally considered for a roadmap, and then they pulled back. So I think that's the bottom line, and that's what it's all about. And it's going to be, I think that your analogy for the HFpEF is right on, is spot on. I would not approach HFpEF patients now with the devices we have. The adverse events are just not acceptable.
So Dr. Torres texting in, not calling in, he's reminding us of the regulatory process in terms of how long it took from all the research in terms of the permanent durable VADs for heart failure reduced EF. Do you anticipate a similar challenge for heart, or even more of a challenge in this patient population?
Yeah, it actually, and it actually relates to the second part of your question, which I didn't answer, which is what is the regulatory pathway? So we had insights into the regulatory pathway because we did submit and got a full approval for an IDE with the Circulite device. And the agency was, let's say, based on the protocol that we submitted, they were willing to consider quality of life issues as the primary endpoint. So the composite success criteria was patient alive, patient did not get hospitalized, patient did not require a full ventricular assist device, and patient exercise tolerance improved, VO2, by VO2. So there was basically, I think that was those are the main 4 components. So survival was one part of it, but I believe that there's a lot of sympathy at the agency for quality of life. And certainly the payers are very interested in quality of life also. So I think that there is a path forward. It's not going to be short, to Guillermo's point. It's not going to be short, but I think there is a way forward.
Dr. Burkhoff, thank you. Fantastic discussion.
Thank you.